Buenos dias. Is more or less what I can tell you in Spanish. No, I mean I know other things, but I'm conscious that my Spanish is not very valid to discuss all the things we are going to illustrate. But I would like to thank intensely all the Sanofi Genzyme organizers and the clinical organizer as Jordi, I know since several years, as other in the audience, and Dr. Solera for this very kind invitation. And every time I come in Spain for meetings or other scientific or clinical reasons, it's always a pleasure, great pleasure. I feel really at home, and also because of the friendship the colleagues have to my person. So I will try to explain and to discuss with you these important recommendations we have condensed recently about POMPE disease treatment. So I suppose that this paper is very commonly known to all of you because it's the first paper that started our problems in some way, because after that the possibility to treat patients with POMPE disease became a reality. And this paper showed what we all know, that the enzyme replacement therapy is able to prolong the distance walked examined with the 6-minute walking test, as well as to give us some important responses about the predicted forced vital capacity. And this paper showed that both of these conditions were improved in the patient examined. I would like to remind you that 90 patients were examined at that time, but 60 were treated and 30 not. So this was an important issue because after that we can refer to the natural history of the 30 patients untreated for several respects. And after that, so there was in every country there was the feeling that we have to have rules about regulation of ERT for patients. And also in Italy we have done a document trying to put together all the knowledge in that field at that time, and ending our document saying that patients with overt POMPE disease had to be treated, which is quite simple apparently. But after that, several other countries edited recommendations, and I don't want to go deep in this field at this moment because there are several different recommendations from Belgium, from Brazil, from Argentina, from Spain, from several countries. But what was a little more relevant for several years was this consensus that has been led by Ed Kupler, and then it's an American consensus, and they try to explain to advise us when to consider the ERT, either for symptomatic but also for pre-symptomatic patients. You can see here two different categories, without objective signs and with objective signs. And after that, we had that somehow a guide for treatment, but there was something that was quite perplexing to us. how can you classify pre-symptomatic patients with objective signs? In other words, when you visit the patient, you see that the patient has a muscle weakness, or when you see that the patient has respiratory problems, is this patient pre-symptomatic? We didn't think like that. So there was a necessity to try to use this recommendation and to possibly improve them. And also, in those years, there was this funny situation. You probably remember that. So the Switzerland Ministry of Health decided to stop the administration of ERT to patients because there was a discrepancy between the effectiveness of the treatment and the cost. But surprisingly, after a year, they changed their minds and they allowed again to use ERT, but what happened clear to all was that patients that had stopped the treatment and they resumed the treatment after a year, they were not at the same level of quality of life as before. So there was in between a loss of time in terms of treating patients. But more recently, several recommendations, and I would like to just to draw your attention about the very last attempts of recommendation. This is one of I really consider interesting, and this is a Brazilian recommendation. And what they outline is that for asymptomatic patients, they ERT should be considered, of course, when symptoms appear, but also when the patient is not asymptomatic, because when you visit him, you can find that there is a muscle weakness, so it's not asymptomatic. But also, this is important to take in mind, when you can find or a typical valvular muscle biopsy or a drop of more than 10% in sitting or supine forced vital capacity. Those are very important points we will discuss later. And this is another recommendation I read with interest from the MENA, in other words, from Middle East and North Africa region. And again, you see here that pre-symptomatic patients, they advise to treat in case of course, when there is a symptomatology coming, or patients with abnormal muscle MRI or abnormal muscle biopsy. So this is something that we have to take in mind. But before going to the last recommendation edited by EPOC, or European POMPE Consensus Network, I would like just to go through a number of interesting reports that have studied the effect of ERT in a large cohort of patients. This was the study we have done in Italy on 74 patients. What we found was something that was already accepted from the scientific community, that patients increased distance in 6-minute walking test and had improved or stable forced vital capacity. But what was, in my opinion, more interesting was the reduction of number of hours or day of assisted ventilation in these patients. So here, another interesting result. This is the paper regarding the same patients that were studied in the New England Journal paper at the beginning, and they followed up this patient till 104 weeks, because the initial study was 78 weeks. And what they found was that there was a maintenance of improved walking distance and stabilization of those patients. In 2013, we decided to review with Benedict Schoser the more important studies, 21 studies with a large cohort of patients, to check what was the real effect of the ERT in this large number of patients. We put together 368 patients with, of course, the late onset form, and what we found was that improvement or stabilization of clinical parameters, i.e. motor and respiratory activities, were in over 2/3 of LOPT patients. Going, at the same time we published that paper, there was another paper from the Dutch group, very important, because they studied the 69 patients, and what they found was that the muscle function was, the muscle strength increased as well as the forced vital capacity, but when measured in upright position, not in the supine position. And I also gave some interesting advices about favorable prognostic factors as, I don't think it's working, as female gender for muscle strength and younger age and better clinical status. So these are important prognostic factors for those patients. Another paper regarding the survival. They studied the survival rate in a large group of patients, 283, and what they found was that the hazard ratio was 0.41. That translated in percentage means that around 60% of patients treated were much better than the untreated patients. And this is another study coming from UK, from the group of Robin Lackman, and what they found was that there was a significant increase in distance walked and muscle strength, but surprisingly, the respiratory scores were not significant in that group of patients. I would like to spend some words about this paper, not because it's from an Italian group, honestly, but it's a group of Bruno Bembi, who is a very distinguished pediatrician, Italian pediatrician, but because it's peculiar. I think that you probably don't see exactly what is here, but I'll try to describe to you the results. So they studied a longitudinal study in 8 patients, but those 8 patients were started to be studied when they were very young. You see 1 year, 2 year, 4 year, 9 year, 8 year. And the diagnosis was a bit later, because you see the diagnosis is 2 years, 9 years, 15 years, 10 years, 9 years, so not really quick. But when they started to be treated, only 3 out of 8 were symptomatic. The others were not were slightly symptomatic. Some of them had myalgia, some others only hypercemia. But they were treated with ERT, and after a while, when they were controlled, only one was in the sitting, only one had a wheelchair, and only 2 had respiratory problems. So this is important because it's something that is still debated, and we will go back to this problem later in discussion if you like. So again, another group from UK, led by Mark Roberts. What they found was that they studied 22 patients, and what they found from the respiratory point of view, that 17 had a stabilization of the symptoms, even to 5 years after starting ERT. So this, in some way, was one of the rare studies that showed us that the improvement, especially for respiratory problems, was longer than thought at the beginning. The Dutch group also studied by a questionnaire methods the quality of life and the participation in daily of life of patients. And they had the chance to compare patient treated and untreated, and of course the participation and the quality of life in patient treated was much better than the others. And this is the last paper of this series, was the second review we have done, including all the studies included in the first review and the following ones. And what we found was a confirmation that either a stabilization of respiratory parameters was present in this, and you see that here we are around 40 months after starting the ERT. And you can see here in the 6-minute walking test, there are patients that improved, but there was a little decrease till 75 months. So it's a quite longer period rather than thought before. So summarizing, what are the most relevant facts in this long period after the New England Journal paper came out? So it has been demonstrated that in late onset patients, the ERT can change definitely the natural history of Pompe disease, and that when you treat the patients, at least 2/3 of the patients have an improvement rather than untreated patients. So we also know that the major efficacy generally is shown, it has been shown in the first 2 years, but we have now proofs that this efficacy can be prolonged over 36 months, and also that ERT is really strictly connected with the better survival. And still, we add some more prognostic factors, because apart from female gender, for muscle strength, younger age, better clinical status, but also early start of ERT. So the only thing we really need now is to have a larger number of studies with a longer distance, a longer length of treatment after the start. So this, considering all these facts as premises of the recommendation we delivered in the European Journal of Neurology, we can go now to the story of the epoch. We funded the European Consortium for Pompe disease, and this has been at the first meeting in Arden as an EMC meeting. And in this meeting, we wanted, as a first act, to study this is the logo of the European Pompe Consortium that has been funded in Munich in 2015 with a number of European colleagues. Some of them are present in this audience. And this is the first meeting after foundation. You can recognize here Hans van der Pleg and Benedict Schoser, who is the chairman, and also Jordi Manera, who is our today's chairman. And this was the first result of this collaboration, large collaboration. So to assess the minimal data set for adult patients, in other words, what we really should do to follow the patients after starting treatment. It's not many things. This is important because we all know that if we have too many things to do, something can go wrong. So it's better to have very focused actions, and you can see here different clinical domains for skeletal muscle strength, function, pulmonary function, and other important studies for fatigue, for participation, and so on. But the main problem was still there, to treat patients or not to treat. So when we have really to start correctly the treatment. And this was the result of our efforts. We studied all the literature, we reviewed the literature, we reviewed the different clinical conditions of patients treated, different geographic origin and different groups. And in fact, at the end of the study, you can see that there were several reports coming from different countries, European and not European, as for example, Japan or Korea, South Korea. And we put together the results of 1,349 patients to propose the recommendations. And here the recommendations. So there are some important points I try to outline, and of course, I will be available to discuss with you all later, if you like. So the first point is the diagnosis. We really need to have a correct diagnosis. And we need, after, for example, having done a DBS, which is a screening tool, it's not a diagnostic tool, to have a confirmation by biochemical testing in leukocytes, fibroblasts, or skeletal muscle, and or demonstration of two mutations. So both alleles have to be mutated to say definitely this is a POMPE disease. This could be the main result, or this could be the second result after the biochemical confirmation. They both have equal dignity. But we know that because there are several attempts to reach genetic therapy, so it's important to have the genetic determination of the mutation in POMPE disease for future studies, for future trials. The patient should be symptomatic, and this was another great debate, who is symptomatic, who is pre-symptomatic, but if pre-symptomatic has to be regularly monitored, still there is the evidence that is symptomatic. We haven't detailed this by different clinical instruments as MRI and muscle biopsy or other tools, but this is just a general statement. When he is symptomatic, he needs to start the therapy. And also, the patient should be compliant, because it's important that he regularly goes to the hospital, to the surgery to be infused. Otherwise, it's, of course, useless. And also the clinician is involved, because the clinician in some way has to be compliant too. So he should check the patient and the infusions. And this is another important point. Sometimes there is a great debate about starting ERT in patient wheelchair bound or patient with assisted ventilation. And this is something important, because we think that they should have ERT, because we need to try to maintain the maximum of the activity from the motor or respiratory point of view. And I'll show you some papers about this, even recent. And finally, if the patient have another life-threatening, although he has another life-threatening illness, there is no point if it's still useful for him to not to deny the treatment. So I just wanted to go back to this point to outline that even in 2013, with this paper led by Andrea Vianello, who is a very distinguished Italian pneumologist, The patient studied, at the end of the study of this patient, we assessed that ERT reduced ventilator dependency and the need for hospitalization. So this patient were not obliged to go recurrently to the hospital with the treatment. But more recently, this here paper is a group from the French group led by Pascal Laforêt. They studied a small group of patients that were already wheelchair-bound and with assisted ventilation. And what they found that some of these patients, not all, but some of them still had a mild benefit from ERT in terms of increased time of autonomous ventilation or enlarged distance of assisted walking. So this was one of the important points that we try to illustrate. So now let's take this other point. So recommendations for stopping treatment. This is it's not surprisingly, I would say. So several things were already applied, and you can see here when the patient suffers for the infusions, or when the patient has a very high antibody titers, very rare in my experience and also in the worldwide experience, is very rare. The patient wishes to stop ERT, of course. The patient is not compliant, as I said before, even on the other side. The patient is not really convinced, likely, that ERT can improve his situation. The patient has, again, another life-threatening illness, and the moving to a center where he should be infused is not advised in the situation determined by other life-threatening illnesses. And this is important because we should check after 2 years the relevance of the treatment. If the treatment still has generated improvement or stabilization of the patient, everything is okay. But if there is something that is not really efficient, we should think of stopping the treatment. But this is another important passage. After stopping, if you see that the deterioration of the patient is going fast, so in other words, likely ERT had the reason, so we should think about, and we could restart ERT. And finally, this is another not trivial point. Continuation of ERT can be considered during pregnancy or lactation. And I'll show you some papers regarding these two conditions. This was the first experience reported by the Dutch group, by Juna de Vries, and she said that in this case, this woman had a normal pregnancy and delivering, and the baby was healthy after continuing ERT during pregnancy. More recently, there are not much, but several others, reports. For example, this by the German group, multiple successful pregnancies. This is a very peculiar case where a woman had a pregnancy and he wanted to interrupt ERT, and she had a couple of children, twins. She restarted ERT, and then she had another pregnancy, and she stopped the ERT, but after that she started again the ERT. And at the end of this long story, she was still in a good condition, although in some passages during the pregnancy she had some worsening of the clinical situation. But there are other cases. For example, this is another group of patients studied in the Royal Free in London. And what they found was that some of those patients asked to stop the ERT in the first trimester of pregnancy, but they wanted to resume the therapy in the second and third trimester. Or some of them wanted to continue. As for example, this is another case from German colleagues. Also, this woman, 25 years, wants to pause during the first trimester, and then she restarts in the second and third trimester. And apart from another problem, cystitis she had after the delivering, the situation was good. She had a good pregnancy and no problem for the baby. And this group of Turkish colleagues summarized several cases in this paper and also discussed patients with cesarean delivery and postpartum management. And at the end of the summary of this case they examined, the most relevant thing is that the patients can continue ERT during pregnancy. Some patients wish to stop in the first trimester, but they want to continue later. Some of them want to stop and resume the therapy after. The general trend seems that have demonstrated that some of them without ERT had a worsening, but after the pregnancy, resuming the ERT, they went back to the previous condition. So this is the general trend coming from this not many cases reported. So in conclusion, we now have a new European recommendation for starting and stopping ERT. And this is something that is important. It's not the end of the story, but probably is a median passage. Likely we have to improve other aspects of the recommendations in the future. In clinical practice, we recommend that specialized centers should deliver these recommendations. And finally, and I want to remind you what I told you about patient pre-symptomatic with muscle biopsy that shows a degeneration of muscle MRI, particularly compromised, although the clinical aspect is considered normal, we should think about, because management of particular conditions of these cases need to be carefully evaluated. So don't forget that we are medical doctors, and beyond the recommendation, sometimes we have to decide independently. So this is the place where I live, and this is the group I work with. This is the network, Italian network, composed by pediatric units and neuromuscular units. And this is the main person I work with in Italy. This is the main person I work with in the European POMPE Consortium and abroad. And this is the Strait of Messina, and here is our place. Thank you very much.